So just let me know when I can share again. Okay, I'm sorry.
Good job, Prashant.
Hey, thank you.
Yes.
I think we need to get started. Maha, take over.
Okay. Hi, good afternoon. I'm Mahalakshmi Sadhu, and I'm a primary care physician in Centerville. Today, MVAPI has organized as part of the wellness series. This is a talk about diabetes. Yes, 1 in 6 Indians is affected by this disease. So either we have a family member or we know of someone who is affected by diabetes. Yeah, to learn about how to prevent complications if you already have the disease. We have Dr. Mina State University in Dayton, and she's a practicing physician at Valley Medical Primary Center. And she's also a primary investigator at Valley Medical Research and the medical director at several nursing homes. She earned her medical degree at University of Bombay in Mumbai and did her residency at Sinai Hospital in Baltimore, Maryland. She's board certified in internal medicine, geriatrics, and hospice and palliative care. Our second speaker is Dr. Prashant Kumar, and he's an endocrinologist who works for Wilson Health in Sydney, Ohio. He graduated from Madras Medical College and did his residency at St. Peter's Medical Center in New Jersey. His fellowship, endocrine fellowship, he completed at Boston Medical Center and has been in the Dayton area since 1996. I'm going to have them start their presentation. Nakshi?
Okay. So did you want to thank the...
No? Okay.
Yeah.
All right. I would like to thank the Public Health Department and Five Rivers Health Center in helping with organizing and spreading the word regarding these talks. Now, we do have, MVAPI has organized some series, a wellness series, some programs that they have on a recurring basis. We have yoga every third Sunday at 5 p.m. and meditation on Wednesdays, every Wednesday at 9 p.m. And Zumba we have every first Saturday. Now we're going to add the fourth Saturday also because of, requests from people who have done it before. So it'll be 2 Saturdays, first and the fourth Saturday. Flyers will be coming out for all of these. Please participate because yes, this is all essential in preventing diabetes. Go ahead, Meenakshi.
All right. Good afternoon, everybody, and thank you for joining in. We are trying a different approach this time in terms of presenting the information. So the first part, I will do a little bit of didactic presentation just to get an idea of the disease state and what's changing in terms of treatment options. And then we're going to hear from Dr. Kumar, who is going to present some cases so that you have an idea of where you are and what you might be able to do differently to manage diabetes. Additionally, we will have plenty of time at the end for questions and answers. And so please make sure you keep typing in the chat box, and Mahalakshmi will be able to keep tabs on that and ask us those questions at the end. So having said that, let's go ahead and get started. So why are we talking about diabetes? Because diabetes in South Asian Indians is a huge problem. India has the second largest number of people with type 2 diabetes globally. And by 2030, it's projected that 79.4 million people are going to get diabetes, which is going to be the largest number in the world. We have 2 to 4-fold increased prevalence of diabetes compared to other races. Why is that? The theory is that there is some increased genetic susceptibility, which is why we are more prone to having diabetes. But additionally, our lifestyle is also conducive to developing diabetes because of physical inactivity, increased caloric intake, and obesity. Having said that, I can tell you that in my practice, I have a lot of Indian diabetics, and most of them are actually not obese by American standards. So obesity or overweight, even by American standards, is a BMI of greater than 25. That does not apply to Indians. We become overweight at a BMI of 22. So unfortunately, and my nurse always comments on this, she's like, oh my God, you Indians, you're skinny, but yet you have diabetes. And so we have a high degree of insulin resistance. So there was a study, it was called the Masala study for 150 Indians in the Bay Area. And what they found was, 29% had diabetes, 37% had pre-diabetes, and only 34% had normal glucose tolerance. So this is a very, very important disease for us. And if we don't manage it well, I'm going to talk about what the consequences of this are. So the genes associated with diabetes include, I'm just putting the names out here just if somebody wants to research that more, but these provide strong evidence of independent association between type 2 diabetes and these genes. And unfortunately, being Indian, I guess we have a strong math gene. We're all fairly good at math, but we're also having a very strong diabetes genes, and therefore we are much more susceptible to having diabetes. So what can you do to prevent diabetes and or treat it? So lifestyle is the most important. I think Prashant is going to go through some specific information as it relates to the Indian diet, but nutrition is very important. A lot of us are vegetarian, but that doesn't mean that we eat healthy. We eat a lot of fried foods and sweets, and that can create a problem. So unfortunately, being vegetarian, sometimes protein intake is not as good as it would be if one was eating meat, but a plant-based diet is in the end still better than a meat-based diet. So, whoops, sorry. All right, so as you look at lifestyle, physical activity is also very important. So 150 minutes a week of moderate exertion, which is walking, gardening, climbing stairs, some strength training, all of those things are important. So 150 minutes a week is 30 minutes, 5 days a week. So that it's pretty intensive activity. So it's not strolling or taking a walk. When you take a walk and you're taking 20 to 25 minutes to walk that mile, it's not quite the activity that they're talking about. Sleeping 6 to 8 hours a night, some of us just don't manage good sleep hygiene, and that can create a problem. A lot of us also have sleep apnea. If you're having disturbed sleep at night, waking up often, or feeling sleepy during the day, then consider having a sleep study to see if you do have obstructive sleep apnea. Of course, some people are depressed and go to food as a comfort. And so if there are mood changes, then actually addressing the mood changes and helping manage those will also help manage the eating habits. And then, of course, smoking cessation. So smoking is not as much of an issue here in the US amongst the Indians as it is amongst the Indians in India or the Europeans. But smoking cessation really is a big problem. So this is not just, these changes are not necessarily just related to Indians. This applies to all populations who have diabetes. All of these things will make a difference. All right. So the pre-diabetes algorithm. So what does pre-diabetes mean? It means that your hemoglobin A1C is not quite normal, but it's not abnormal enough for us to necessarily warrant medication therapy. And so if you want to avoid starting on medications, then things to do would be weight loss therapies, managing your high blood pressure, managing your cholesterol, because all of these in the end interact to cause disease, to cause complications of diabetes. So if you look at just hyperglycemia or blood sugars, if you have a fasting blood sugar of greater than 100 or 2 hours after you eat, if the blood sugar is greater than 140, that kind of meets criteria for pre-diabetes. Okay, so if your hemoglobin A1C is between 5.7 and 6.2, you could be considered having pre-diabetes. Higher than 6.2, we start considering you as having diabetes. So weight loss therapies, and some people might choose to, this would be offered to you and you might choose to start treatment with metformin, 500 milligrams twice a day, to help lower the risk of actually getting into full-blown diabetes. And I'm sure Dr. Kumar will comment on this further as we get along. All right, so what about cholesterol and high blood pressure? Those are two very important comorbidities or other diseases that kind of go hand in hand with diabetes to increase the risk of heart disease, stroke, and ultimately death. So in terms of cholesterol, you know, the numbers are there listed on this page. The idea is that if you have multiple risk factors, you have high blood pressure, you have diabetes, you have high cholesterol, you have kidney problems, we try to really manage those numbers quite closely. And so depending on the risk level, you would want to have your LDL, for example, less than 70, your non-LDL less than 100, your triglycerides less than 150. ApoB is not something we measure very often, but if you were to measure it, you want it to be less than 80. So how can you manage this? You can certainly manage it with medically assisted weight loss, but you can, and altering your diet. But a lot of times there is some genetic component to it as well. And so no matter what you do, those numbers are not moving. And you would need to get treated with either statin therapy or other options. You have Zetia, you have the PCSK9 therapies, and there are some newer agents available. So this is not a talk for lipid management, so I'm not going to go into too much detail with it. Just suffice it to know that there are multiple options. If you don't tolerate a statin, we now have other different options that you can use to manage your cholesterol. The other thing you want to do is to manage your blood pressure. So a lot of times folks used to think, well, I'm 60 and over, so if my blood pressure is 156/90, that's okay because I'm older. Well, it really is not okay. And there's multiple studies showing that especially for diabetics, you need that blood pressure to be even lower. Most of the time, we try to start treatment with what we call an ACE inhibitor or an ARB, which is typically in this day and age, we're using lisinopril or losartan or valsartan. So those agents help to protect the kidney. But then if your blood pressure is not well controlled with that, or if your initial blood pressure is really high, like 150 over 100, then you would start with two agents. So one of them would be an ACE or an ARB, but the other would be like a calcium channel blocker like amlodipine or nifedipine, or a beta blocker or hydrochlorothiazide or chlorthalidone. So those things would help to manage your blood pressure to the goal of less than 130 over 80 for most people. If you are old, 85 plus, we might have a goal of 150 over 90 based on other risk factors. So I wanted to spend a moment to talk about this slide because this slide will help you understand how each agent works in terms of treatment. So we have the pancreas, we have beta cells in the pancreas, we have alpha cells in the pancreas, we have the liver. What happens in the liver is that there is increased production of hepatic glucose, which helps to increase the blood sugar by reducing the amount of, by increasing the amount of glucagon. Then we have the incretin effect in the intestines, and we're going to talk about that a little bit. We have the fat cells that are involved as well. We have a newer class of drugs that works at the level of the kidney, and what it does is it lowers the threshold at which glucose is excreted in the urine, and so you need a working kidney for that, for those products. We have agents that actually increase glucose uptake in the muscle, and those agents which increase glucose uptake in the muscle are those which help with insulin resistance. And then you have some agents that will help to make you feel full. So there's a center in the brain, it's called the satiety center, and it some agents will work on that to help you feel full. So some diabetics are hungry all the time, and that's why they have a much higher caloric intake than is necessary. All right, so person-centered care is important. It's not a one-size-fits-all. A younger person, a newer diabetic, we're going to be a little bit more aggressive in trying to get to a goal. We're going to get to a more tighter goal. If you are 70, 80, you've had diabetes for a while, the goal can be a little bit looser. So we could go for a hemoglobin A1C between 7 and 8. And if you are old, almost to the end of life, the goal could be even less kind of restrictive. So it's very important to review and discuss your management plan with your clinician so that both of you are on the same page in terms of what are your goals of care. And the goals of care ultimately are to help prevent complications of diabetes and optimize the quality of life. So, you know, it's shared decision making between you and your provider, and ultimately what you want to do is to reduce the risk of cardiovascular disease and kidney function. All right, so this also just kind of goes through the same way. I love this slide because it goes from, you know, if you have a high risk of having hypoglycemia, say you're older, but you don't have any support system at home and you're worried about having multiple insulin injections in a day and having low blood sugars, is there somebody to help you manage? And if not, we need to find a regimen that will help support your particular lifestyle, your life expectancy, comorbid conditions, and vascular complications. So things have changed in 2021. Both the ADA and the AACE have recommended simplified regimens rather than very complex regimens so that people can manage them well. So goals for patients without concurrent serious illness and at low hypoglycemic risk, the hemoglobin A1C goal is less than 6.5. But for those with serious illness and at risk for hypoglycemia, you could have a goal, like I said, of less than 8. So we talked about lifestyle therapy and ASCVD factors or risk factors. What is interesting is that a lot of us initially were started on medications we call sulfonylureas like glipizide and glyburide, but that is now much lower on the list. We're trying not to use those medications because they have not shown any proven cardiovascular benefit. In fact, they can have cardiovascular harm. And two agents that cause the most risk for hypoglycemia are the sulfonylureas and rapid-acting insulin. So if we can avoid those in the regimen, we will reduce the risk of hypoglycemia. So if you talk about a single drug, metformin is still the one that we would use most often. It's cheap and it's effective and it doesn't cause hypoglycemia. The side effects are nausea, vomiting, diarrhea. Sometimes it's bad enough in people that they're just not able to tolerate metformin, and that happens in about 5 to 8% of folks. If your kidney is not working well, so if what we call your estimated glomerular filtration rate is less than 30, then we shouldn't use metformin. If it's between 30 and 45, we can use half the daily dose of metformin, which would be 500 milligrams twice a day. If it's greater than 45, we can use metformin full strength, which is 1 gram twice a day. But other agents have been now added into the monotherapy group, one of which is the SGLT2 inhibitors. This is a wonderful class of drugs that has come to be in the last 2 to 3 years. And how they work is they work by reducing that threshold at which sugar is excreted in the urine. So these agents, the ones that we have available to us, some of them are Invokana, Jardiance, Farxiga. Those are the class of drugs we're talking about. They also help to reduce cardiovascular risk. So they're of benefit if you have heart disease. They're of benefit if you have heart failure. And so one of the other recommendations from the ADA and the ACE in 2020, 2021 is that if you have either cardiovascular disease or risk factors for cardiovascular disease, like high blood pressure or high cholesterol, then we should use one of these agents, which is either the SGLT2 inhibitors or the GLP-1 RAs. So the SGLT2 inhibitors are medicines that you take by mouth, and typically they're once a day. They can also cause weight loss, and they are helpful or beneficial for protecting the kidney as well as for heart disease. And again, Prashant will probably talk more about this in his cases. The GLP-1 RAs is another class of drugs, and those are injectables for the most part. We have one oral GLP-1 RA, but most of the others are injectable, and they can be twice a day, once a day, or once a week. And they are a great class of drugs because they can be used if you have renal failure, heart failure, hepatic failure. It doesn't matter. They can be used. They can also cause weight loss, and they're also, depending on the drug, have cardiovascular benefits for that class of drugs. The DPP-4 inhibitors are agents that we are using less often now. So those are like the Januvia, Onglyza, that class of drugs. They're weaker agents. So if you're going to spend money on medicine, then we would rather that you spend it on something like the SGLT2 inhibitors or the DPP-4 or the GLP-1 RAs rather than DPP-4 inhibitors, but they're a reasonable class of drugs. I'm going to take a moment to talk about the TZDs. So the only one that's available in the US is pioglitazone. And while these drugs are not used as much, I think in the Indian population, they have a special place because they are the ones that lower insulin resistance. The unfortunate part for the TZDs is that they do cause weight gain. And so for most of us who are already struggling with weight, that can become a problem. But they do lower insulin resistance and they're quite effective. They have a low risk of hypoglycemia. So if this doesn't work, then you would add, if just one agent doesn't work, you would add a second agent or a third agent. and ultimately you would go ahead and add insulin. So about 5-6 years ago, we were pushing for adding insulin earlier in the regimen, but now both the ADA and the AACE ask us to try these other medications first before we add insulin because they have the added benefit of helping to improve cardiovascular mortality. So if you're going to add insulin, you would start with an insulin that's a long-acting insulin, and you would titrate it up till your fasting blood sugar was at goal, depending on what your goal A1C is. It could be less than 100 or less than 140. And you would titrate twice a week till you get to that goal. And then you would stop titrating the long-acting insulin. If your blood sugars are still not at, after you eat, if you're still having high blood sugars, then you would add mealtime insulin to the regimen, and you can add mealtime insulin 1, 2, or 3. Right, so this is giving us a good profile of all the agents that are available and what issues you have. And what you see is hypoglycemia is high with sulfonylureas and with insulin, but really not so much with any of the other agents. In terms of weight gain, again, you see weight gain with TZDs, which is pioglitazone, sulfonylureas, and insulin. The SGLT2 inhibitors and GLP-1 RAs cause weight loss. Actually, if you use them together, I have seen as much as a 50-pound weight loss, and I'll be interested to see what Prashant has seen. But you can see some fairly significant weight loss with the combination of these drugs. If you have kidney disease and your GFR is low, you kind of only have a couple of options. One of them would be the GLP-1 RA, the other would be insulin, and so on and so forth. All right. Okay, I didn't want this. So we did talk about hypertension. Again, you want to try to use lifestyle modification and 1, 2, or 3 medications to bring the blood pressure to goal. Most of the time, your physician will check your urine for albumin in the urine or microalbumin in the urine, which is an early predictor of having kidney problems. And if so, they will definitely start you on an ACE inhibitor or an ARB. And you will need to be monitored periodically to make sure that the blood pressure is under good control. All right, I'm just going to take a couple more minutes to talk about preventing rather than managing complications, but what are the complications of diabetes? And diabetes is a silent killer, and it affects every organ from the head to the toe. So the foot exam is important. We'll start with that. And this is a mnemonic. So if you have deformity, if you have infection, if you have nails that are thinning or breaking down of skin, swelling in the legs, cold feet, ischemia, callosities, or skin color, all of these things are important to tell you that you have some issues which are complicating your diabetes in terms of your feet. So typically, again, when you see a physician, they will check your feet at least once a year. They will do a test with what we call a monofilament, which is just a small little wire. And it just tests to see if you have sensation in your feet so that they can be alert if you don't, to warn you about the risks of having ulcers or infection in your feet. What about the eye? So the eye, diabetes is the commonest cause of blindness in the age group between 30 and 69. So if you want to protect your eyes, you want to make sure that you've got your diabetes under good control. Damage to the retina arises because of a combination of microvascular leakage and microvascular occlusion, which means there is leaking of blood in the retina. And interestingly, about 1 in 5 people who are diagnosed with diabetes, and this included my father. My father, at the time of diagnosis, already had diabetic retinopathy. So, it just goes to show you that people who have diabetes don't necessarily know that they have diabetes by symptoms. The typical symptoms are you feel more thirsty, you feel more hungry, and you're going to the bathroom more often. But a lot of times it goes undiagnosed for years, and sometimes you already have complications of diabetes like eye disease prior to actually being diagnosed. So the prevalence of eye disease, the total number of people with diabetes, is projected to rise from 285 million in 2010 to 439 million in 2030. The pandemic didn't help us at all. All of us were isolated, and we were less likely to do activities. We're sitting at home and watching television more, and so that's adding to the issue. Diabetes remains the leading cause of legal blindness in the Western world, and it's responsible for 1.8 million of the 37 million cases of blindness. So it's kind of a huge problem. And if you want to save your eyes, you want to make sure that your diabetes is under good control. So it affects the kidney as well. And 40% of new cases of end-stage kidney disease are attributed to diabetes. So hypertension is another big cause of end-stage renal disease, and as you can see between the two of them, at least 2/3 of the end-stage kidney disease is accounted for. It affects the nerve cells. About 60 to 70% of folks with diabetes have mild to severe forms of nerve damage, and how that presents to you is you have this tingling or numbness in your feet, you have an impaired sensation. So you can also have that in your arms, but hands, but typically in your feet. And more than 60% of non-traumatic lower limb amputations occur because of diabetes. So what about other complications? You see that diabetics have heart disease, and so these are called macrovascular complications. So they have angina, heart attacks, strokes, limb problems. You have pain in your legs, in your calves, because of decreased circulation in the legs, and that's called claudication, and you can have amputation as a result of that. So we talked about modifiable risk factors, of course, smoking, inactivity, nutrition, obesity, and alcohol intake, lifestyle modification. Okay, so I think I'm going to stop there and have Dr. Kumar kind of present cases. And then I think we'll have a lot of questions at the end, I'm sure. And so we'll be able to answer some of the questions that you have.
Good afternoon. Can you hear me?
Yes.
So Meenakshi, should I have to do something here different? I'm sorry, gentlemen, ladies, I'm technologically challenged.
Do you want me to share it?
I think I should be, right? I just go to hit the share screen, right? I think I should
Yes,
be.
yes.
Just give me a second here. Can you see the first slide?
No.
No. So do you want to go ahead and do the first slide then, Meenakshi? Can you hear me at least?
Yes.
Can everybody hear me?
Yes, yes, we can hear you.
Yes. Good afternoon, everybody. And again, thank you for joining us on this spring afternoon. I'm sorry it's a little gloomy out there, but still it's beautiful. The spring is very much here. Although the talk is about diabetes, I think it looks more like an afternoon for some nice hot chai and samosas. First of all, I'd like to take a moment here to thank all our healthcare heroes for their hard work, commitment, and their sacrifices. I'd also like to take a moment to remember the so many we've lost prematurely during this pandemic. Our thoughts and prayers are with their families and loved ones. I'd like to thank the Miami Valley Association of the Physicians of Indian Origin for putting this together, giving us an opportunity to share our thoughts, experiences, recommendations when it comes to taking care of the individuals who come to see us for their diabetes management. Thank you, Meenakshi, for this excellent informative presentation. I think Meenakshi has done all the heavy lifting, and I think I can go home now. I'll try to go ahead with some case scenarios. Probably many of them would be repetitive. I think there's going to be a lot of overlap between what Meenakshi has already alluded to. But I'll start with this gentleman here with, let me start with the first patient here. So it's a little bit of a different scenario than what Meenakshi has talked about. So here is somebody, a 24-year-old, referred by primary care, presenting to their office with classic symptoms: polyuria, polydipsia, a blurring of vision, and a 10-pound unintentional weight loss. And the random finger stick glucose was 350. So I'm sure everybody would agree that this gentleman has diabetes. So if you look at diabetes criteria, the criteria to make diabetes is anybody with a hemoglobin A1C of 6.5 and above, or a random glucose of more than 200, presenting with classic symptoms of polyuria and polydipsia, or a fasting glucose of more than 126. So this gentleman meets the criteria clearly. And we confirmed the labs. His glucose was 342. Renal functions are unremarkable. Urine analysis was done. I think it's important. Just to make sure that they do not have large amounts of ketones. A large ketonuria would increase the risk for ketoacidosis. It may even warrant a decision about sending them to the hospital for IV hydration, and even possible an overnight stay in the hospital. In the good old days, we'd probably be admitting them and treating them with fluids, having them go through a comprehensive education program. And there were times when I first started the practice of medicine or while in training, we would intentionally cause hypoglycemia so that they understand what the symptoms are and what to look out for, which of course we cannot or should not be doing anyhow these days. So this gentleman has diabetes. His A1C was 12. He happens to have no family history of diabetes. Are you with me, Meenakshi, on the slides?
Yes.
Yes, sorry. So his past medical history includes primary hypothyroidism from Hashimoto's. He's on levothyroxine. And health examination was unremarkable. Clinically euthyroid, normotensive. As you can see, he's thin, weighing being about 5 foot inches tall, and weighing only about 132 pounds. Interestingly, he also has some vitiligo, and the rest of the examination unremarkable. So in summary, this gentleman has type 1 diabetes. Now, it's quite common for most of us to assume that the young has type 1 and the older has type 2. That's not necessarily the case. And it's quite often believed that type 2 is more prevalent in Indians and type 1 isn't. That's not necessarily true either. We see all these, both these conditions in our population from South Asia. Now, this is important here because we see quite often where this gentleman, this individual could easily be a 64-year-old female. And we would think somebody has type 2 diabetes, but somebody with a body weight which is like in her, looking at her BMI, the BMI of this gentleman, somebody was vitiligo, primary hypothyroidism. So these are all some of the features which go along with type 1 diabetes, and that's why we have to be cautious and not prescribe conventionally used therapies for type 2 diabetes in the individual who's presenting it later in life, but have actually a diagnosis of type 1. So some of these folks, we call them type 1.5 diabetes sometimes because they look kind of a little older, but presenting a little later, not necessarily very thin. Some of them, we use a term called latent autoimmune diabetes of the adult. And in general, we tend to treat these folks like they have type 1 diabetes. So that's where sometimes we need additional investigations. Now, in the slide here, this gentleman doesn't typically need all the additional laboratory data, but if in doubt, I think it's reasonable to measure a fasting glucose along with the serum C-peptide, but it gives us some estimation of endogenous insulin producing capability. As you well know, people with type 2 diabetes are going to be making a lot more insulin, and people with type 1 are going to have probably absolute insulin deficiency or a significant amount, and their C-peptides are going to be lower. In type 1, they usually have features of autoimmunity, and that's when you see primary hypothyroidism, vitiligo, pernicious anemia, probably some folks with Addison's. And then these folks may demonstrate antibodies, and the commonly used antibodies are islet cell antibodies, GAD antibodies, which is glucose decarboxylase antibodies, and zinc transporter antibodies. These antibodies are commercially available. I have not had any issues with regard to insurance denying these tests. So these tests do aid in enabling us to inform somebody that they have type 1 diabetes, and insulin is what they're going to require for the rest of their lives until we have a cure. Hopefully that happens in my and your and everyone's lifetime, because that'll be the holy grail when it comes to taking care of type 1 diabetes. So going back to this gentleman here, of course, we're going to have him see a dietitian and a diabetes educator. There's value to learning carbohydrate counting because it is important to start correct and that'll help these individuals understand that managing their mealtime insulin dose in relationship to their carbohydrate intake goes a long way in improving post-meal glycemic responses, and also probably even minimizing the amount of insulin they need. So this is where I think I can take a small detour and talk about more and more strategies being practiced these days, where folks are following low-carb diets, intermittent fasting, ketogenic diets, etc. So some of these things have to be considered. The jury is still out there. Preliminary data has shown intermittent fasting to have shown us some benefits with regard to weight loss, improving surrogate inflammatory markers, improving glycemic control. But you have to be cautious because some of these folks are at risk for hypoglycemia. They may be using treatments which can cause them to have increase the risk of hypoglycemia. Some of these folks, it may be inappropriate if they're pregnant, if they're lactating, if they have eating disorders. So all these things have to be taken into account when we suggest, or even if somebody is considering a rather intense low carbohydrate therapies. Now, some of these folks also follow ketogenic diets. And do we say no to any of these things? Of course not, but we urge caution. They need to be monitored. They need to be managed closely. They need to be advised about the importance of hydration and keep in close touch with their diabetes team. Particularly the ketogenic diet, as you well know, people with type 1 diabetes are at a higher risk for ketosis. If they omit insulin doses or get dehydrated or forget to take their insulin for whatever reason, they could easily end up in the hospital with ketoacidosis, which has profound consequences. Similarly, the commonly used, at least the commonly used SGLT2 inhibitors, as Meenakshi just alluded to, such as Jardiance, Farxiga, Inokana, etc., are prone to cause what's called euglycemic ketoacidosis. Now, we all believe or know that usually people with ketoacidosis, when they're present in the emergency room, usually have higher blood sugars. But this group of population, or this population of individuals on these oral agents, present with blood sugars in the low 100s and could be ketotic. They'll have large ketones in the urine. Their biochemical parameters show metabolic acidosis, and it can be serious, and they need to be treated, at least in the hospital temporarily, as if they are insulin deficient, and treated with IV fluids, placed on insulin, and re-educated. Now, what we try to do is we not only try to inform our patients who use these kind of oral agents about the possibility of this if they start feeling sick and get dehydrated, but more importantly, we also ask them to educate our fine emergency room colleagues about this possibility of something which they don't see that often. So I'll get back to this individual with type 1 diabetes, and we will go ahead and say, how do we start insulin? Or how many grams of carbohydrates? Typically, we recommend 45 to 60 grams of carbs per meal. Lower carbs are reasonable. I think the American Diabetes Association has finally, with some degree of reluctance, have accepted that maybe low-carb diets are acceptable. So we have a discussion with folks, and if they like 30 grams at each meal, that's all right. But it's more important that they match their insulin to the amount of carbohydrates they consume. So we start insulin therapy weight-based. I think that's the right thing to do. As you well know, each individual's needs are different. We don't use a one-shoe-fit-all approach for our individuals with diabetes. The thinner somebody is, the lesser their insulin needs. The heavier somebody is, the larger their insulin needs. But a standard formula of using anywhere from 0.3 to 0.5 units of insulin per kilogram body weight would be a reasonable starting strategy. So to give an example, if somebody weighed 60 kilograms, they probably need about 30 units of insulin per day. And we start off with giving half of it as what we call basal insulin, which is a once-a-day insulin. And I'm sure all of you are familiar with terms Lantus and Basaglar, Levemir, Toujeo, Tresiba, and of course our good old NPH insulins from the past. These are all the slow-acting insulins. Basically, what do? They help to minimize the high glucose levels from the constant release of glucose from the liver and the muscle. And by administering basal insulin, we are able to have the glucose being utilized to meet your energy needs. And that helps to take care of this constant background of insulin, which all of us with diabetes do not have, but individuals with type 1 who do not make their own insulin. So they need this basal insulin. Now, in addition to that, they need rapid acting insulin at each meal. As you well know, they start working within 15 minutes and typically bring down blood sugars within 2 to 3 hours. So there are different strategies to use when it comes to using mealtime dose of insulin. Some folks are reluctant and get intimidated by carb counting, but this is a relatively simple thing to do now because almost everybody has a smartphone. Apps are available for your phones. Almost every restaurant these days have carbohydrate content in their meals as part of the menu, including our fast food restaurants. So I think it's a good idea to learn how to count carbohydrates. It's very educational. It's very rewarding because that gives somebody some degree of flexibility to take less insulin sometimes, maybe take a little more insulin sometimes. All of us have celebrations, and sometimes there's a need for us to take a little more, although not always encouraged, but it requires somebody to have the degree of flexibility. Now, if somebody cannot or will not learn how to count carbohydrates, we typically tell them, okay, you take 3 units for a small meal, 5 units for a large meal, and we'll take one step at a time, and then make recommendations to make adjustments in insulin doses to meet their glycemic goals. Like Meenakshi said, the goals typically, the younger, less the comorbidities, the longer the lifespan, the more intense our regimen is. The reverse is true if somebody's at the opposite end of the spectrum. So for somebody like this gentleman, we'd like to keep his blood sugars between 70 to 130 before he eats. anywhere between 140 to 180, 2 to 3 hours after each. That is as long as he is comfortable doing this. This is a shared decision. We talk about the need for complication reduction, but we also have to take into account an individual's preference, his comfort zone. And then slowly, this is going to be a large battle. We need to take one day at a time. Let's win the small battles and win the war. So we need to make, because the last thing a young individual or anybody wants to have a bad hypoglycemic event. Believe me, you lose their trust. They lack their own confidence. Their family members get bent out of shape because they've had a hypoglycemic event. So it's okay to take one step at a time and slowly but surely get them into practicing what would be ideal glucose control. Now, how do we determine? Another thing which is commonly seen is sliding scale. We typically discourage a sliding scale. We use a different form, a term for this, what we call insulin sensitivity factor, meaning how much of insulin should somebody take an extra to help control their blood sugar. So we use a formula called the rule of 1800, where we divide 1800 by the total daily dose of insulin they take per day. Say in this individual, if he's going to be taking 30 units of insulin per day, we divide 1800 by 60, that'll be about 1800 divided by 30 units, which will be 60. So we would say in this individual, 1 unit of insulin for a blood glucose level 60 milligrams per deciliter over 120 would be a sliding scale to be appropriate for this individual. So for example, if his blood glucose is 180, he'll take 1 extra unit of rapid acting insulin. If it's at 240, he'll take 2 extra units. Now, this is also important because if somebody is sick for whatever reason, and they believe, geez, I'm not eating, I don't have to take insulin, then what happens is these folks will be in the ER in ketoacidosis. So we tell them, make sure you still take your slow-acting insulin because you cannot be without your slow-acting insulin. Now, we understand your fear of taking rapid-acting insulin if you're not eating. So we tell them, if you're not eating for whatever reason, check your blood sugars. Make sure there are no ketones in your urine. If your blood sugars are running high, use the scale to correct a higher than expected blood sugar reading and keep giving yourself insulin every 3 to 4 hours of the rapid-acting insulin so that this would avoid an unnecessary and expensive visit to the ER or even a hospitalization. So we'll go to the next slide, Meenakshi. So the comprehensive education is important initially, and this is ongoing. And I think all of us or everybody on this panel would agree that we should have an attitude of being supportive. We have to be encouraging. We have to be celebrating small victories. We need to avoid blame or being judgmental. And that's the right thing to do. And it's tough. It's expensive. It's inconvenient. Lifestyle changes are not easy. The constant need to prick your finger, take so many shots per day, at work, at home, when you go out to eat, amongst friends. It's not easy to do. So I think it's important we continue to support and encourage rather than try to be difficult with, we understand it's not easy. We all want people to do well. As physicians, we want everybody to get everything done right. And we get disappointed, frustrated at times. But I think we need to just take a step back and realize that we are not in their shoes. And we have to be, we have to recognize that fact and try to be supportive. I think it goes a long way. It has helped me in my career. I think it helps our patients. And I believe it's the right thing to do because it is tough. It certainly is tough. I'm not sure what I would do if I have the same kind of condition, but I would hope that somebody would treat me well when I had such a condition. Now, again, with regard to additional things which we have to do, Meenakshi has already gone over it, blood pressure goals and strategies to lose weight, immunization, prevention of complications, sick day rules, etc. Now, what would he do? What is a sick day rule? I think it's basically preparing them to manage a particular condition when they're ill. So I'm not feeling well, I have an infection, I'm throwing up. Doc, can I stop my insulin? The answer would be no. You're still going to take your slow-acting insulin. You're not probably going to take your rapid-acting insulin if you're not eating a meal, but you're going to take some insulin to cover up higher than goal blood sugars every 3 to 4 hours. You got to check your urine for ketones. If your blood glucose levels are more than 250, you're going to keep yourself well hydrated with non-caloric fluids. And then if you're not able to keep things down, you have to head to the hospital, because as you get dehydrated, even though you take your injections, the amount of absorption of insulin can be erratic, and you may not have your commonly known responses. And the best thing is an earlier visit to the emergency room with IV fluids would go a long way in a rapid return to baseline back home. I think in this day and age, one should be aware that we have so many options. From where we started 30 years ago, when we had to use the beef and pork insulins and all the lifesavers, I think they had their own set of problems. Now, of course, with all the analog insulins and being more tuned to what our body does, insulins have come a long way. It has made glycemic control doable, manageable. They mimic the patterns which our body would do otherwise. There are delivery systems which can make it easier. So I'm sure you probably have seen folks use insulin pumps. Insulin pumps are an excellent tool. I don't think there is a certain age group who shouldn't use insulin pumps. The key is one should be able to afford it. They should be able to make sure their insurance company accepts an insulin pump as the part of their treatment paradigm. There's some education involved. There's a learning curve, which I think most people can and should be able to do it. I don't think it should be a problem. We have seen folks in their 80s on insulin pumps. I think the FDA has allowed insulin pumps in individuals as young as 3 years. So I don't think that should be an issue. I think the biggest hurdle to an insulin pump is the cost, intimidation factor. Folks do not like to be attached to devices. And there is a perception out there that insulin pump is only for a bad diabetic, or it solves all problems. Insulin pumps are good as long as you work with it. You have to follow the rules. You have to closely follow all the guidelines, what you've been trained, and they really work well. And there are different insulin pumps. There is a tubeless pump called the Omnipod. Now, most pumps have a tubing, and some folks, particularly depending on the kind of occupation they are, they don't like a pump which has a tubing. Now, there is an alternative called Omnipod, which is a tubeless pump. Now, there are pumps and there are sensors. The biggest advantage of insulin pumps is flexibility. Now, I'm sure all of you who've taken care of individuals with diabetes understand their daily routine is not the same. Some of them may be working Monday, Tuesday, off Thursday, Friday, night duty on Sunday. It's almost impossible to prescribe an insulin regimen for these folks. It used to be, at least. Thankfully, with all the newer insulins available now, we can give them a once-a-day slow-acting insulin at any time of the day, and at any time they're going to be eating a meal, they take a rapid-acting insulin. Now, as long as they don't mind the inconvenience of 4 shots a day, that's an excellent option, but it still has its limitations. There are some folks who are low during the night, wake up high. There are some folks who are always high during the night and are really good during the course of the day. So these subcutaneous insulins have their limitations. On the other hand, with insulin pumps, these deliver micro boluses of insulin. We're talking about as low as 0.025 units per hour. So the flexibility is enormous. So if somebody's blood sugars are low only during the course of the night, say between 12 and 3, we give them less insulin during that time. If somebody is high only when they wake up, we ask the pump to deliver more insulin only between 3 a.m. and breakfast. So we can compartmentalize insulin delivery at different times of the day, depending on one's blood sugar profiles. Additionally, if this individual suddenly decides to walk the dog, and now he can tell the pump to deliver less insulin for the next half an hour or 45 minutes. Or if somebody has a planned activity, say an hour or two from now, they can tell the pump to deliver half the amount of their usual insulin an hour before activity, during, and subsequently thereafter. So the key word is flexibility with pumps. Then, of course, you have sensor devices. Now, there are different kinds of sensor devices. I'm sure some of you folks, I'm sure Meenakshi knows this, there used to be a thing called the gluco watch, which you would put on your wrist, just like a current iPhone or iWatches or Apple Watches. They were terrible. They never gave us any accurate data. But at least that was something to think about at the time. Fast forward almost 15 years later, we have sensor devices now. You may have seen commercials called the Freestyle Libre. It's actually a device you put on your arm. You change this every 14 days. You use a handheld device, or they are also adapted. They can be used with your Android and your Apple phone. You just scan it. You scan it before meals, 2 to 3 hours after meals, before driving, walking, etc. And you can look at where your numbers are. It completely eliminates the need for finger stick monitoring. Plus, these devices also have arrows on them, and it tells you, if it shows an arrow pointing downwards, your blood sugars are dropping rapidly. If there are arrows showing, if there are 2 arrows being shown downwards, it's going to be a really rapid fall, anywhere like 60 milligrams per deciliter over the next 20 minutes. So an individual will take appropriate measures, right? Before they drive, before they're active, and they can take a certain amount of carbohydrates to prevent this from happening. They can look at their blood sugar profiles, make appropriate adjustments in their medications, be it oral agents or be it insulin. It adds to confidence. Now, one of the biggest hurdles to accomplishing glycemic control is the inconvenience of finger stick monitoring, the fear of hypoglycemia. I simply cannot imagine how many of my individuals with diabetes would go to bed not knowing what their blood sugars were or never being alerted during the course of the night. Thank God for these devices. These devices alert you. You can set your own low blood sugar profile. You want it at 70 milligrams, you keep it at 70. You want a high of 200, you keep it at 200. You will be alerted to this. And you can change this depending on what your goals are. We have come a long way. Now, we have a newer device called the Freestyle Libre 2. The Libre 1 did not have an alarm feature. The Libre 2 has an alarm feature. Now, there is another sensor called the Dexcom. You've seen commercials on TV. You put it on, it changes every 10 days. It measures your blood sugars every few minutes. You can see it on your handheld device. And interestingly, this data can be sent to anybody whom you prefer. Could be your spouse, your parent, your child, or whoever, so that one could be alerted to any change, metabolically speaking, if they're dropping too low or high. Now, some of the children don't like it because they feel that mom or dad is on their case all the time. But believe me, it's made a huge impact. And the sensor devices are here to stay. And I think, but for some degree of discouragement from insurance companies, otherwise it would be the standard of care. And I suspect it would be in the months or years to come. Already Medicare is supporting these devices. All they require is you need to be on insulin. So Medicare has some criteria. You have to be on 3 shots of insulin per day. And then you need to check your blood sugars at least 4 times a day for 30 days. You do that, you submit that information, Medicare pays for these devices, whether you have type 1 diabetes, whether you have type 2 diabetes, but you should be on insulin and you should be on 3 shots of insulin per day. So basically, what I like to impress upon today is we need to seize all the available opportunities we have today to enable an overall sense of comfort in managing a condition which can be challenging. So they're expensive, of course, but I think one should seriously consider that. Now you have these pumps and sensors which talk to each other, what we call the closed loop systems. So the sensor tells the pump what the blood sugar is, and the pump automatically delivers less insulin if need be. It delivers more insulin if need be. So I think it's, we live in very interesting times. And if I had to develop diabetes tomorrow, I think I'm in a position of tremendous advantage, quite unlike the folks who had this 40 years back. And I think if this strategy continues to be adopted, we are going to see less and less and less of complications, thankfully. But hopefully we all can work together and the costs get lesser. And if we use all these medications, be they oral or otherwise, we can help our folks with diabetes have a good quality of life and be safe at the same time. Now, I had other case scenarios as well, but I think Meenakshi has already talked about all of them. I know there was some question about diet, right? I think particularly when it comes to Indians and people from the South Asian continent, we all understand that diet is not easy. You know, it's not, we Indians are not going to give up rice and potatoes and in the processed food. That's not going to happen. Let's at least be practical rather than idealistic. Now, we all are going to have our Diwalis and our celebrations and everything. It's going to be weddings and all those things. So, if you know, let's give up a few days of being so rigid and enjoy some of this. There's value to living a good life also. But at the same time, should we be following a poor diet? No, I wouldn't be encouraging that at all. And folks always talk about glycemic index and glycemic load, etc. Right? According to the recent paper, or at least what was seen in the 2021 ADA guidelines, studies examining the ideal amount of carbohydrate intake for people with diabetes are inconclusive. Monitoring carb intake and reviewing the blood glucose response to dietary carbs are key to improving post-meal glucose management. So there is literature involving glycemic index, glycemic load, but the literature is complex with varying definitions of low and high glycemic index. It's very complicated. Now, glycemic index actually ranks carbohydrate foods on their post-meal glucose response, and glycemic load takes into account both the glycemic index of food and the amount eaten. So it's not just the glycemic index alone. How much of it I eat is also has to be taken into account. Now, is it a good idea to follow a diet which includes low glycemic index? Of course, yes. But sustainability also has to be taken into account. Now, not all of us are going to be eating only chickpeas and lentils all our lives. I mean, that's not going to happen. But if that can be incorporated into a diet, I think that's good. Less processed food, more complex carbohydrates, more fiber, more grains, less of white rice, less of potatoes, less of white bread, I think would certainly be the right thing to do. But anything in moderation, I think, is the key. Now, studies have found mixed results as to the effects of following a low glycemic index, or some studies have shown not much of a difference. Well, some studies have shown a drop in the hemoglobin A1C of 0.15%. Sometimes it's 0.5%. So I think one has to see what fits into their game plan. We have to look into culture, ethnicity, which part of the world we come from. All these things have to be taken into account. But I think a good mix of all of the above would make managing a difficult condition doable and can be rewarding. I think with that, I'll probably end my talk and I'll open it to more questions. And I'm sure there'll be plenty to talk about. And thank you for your kind attention.
So one of
Love the talk, Prashant.
Thank you very much. Go ahead, please. Any questions?
Yeah, one of the questions is, can you comment on statin-induced hyperglycemia?
Good question. Now, from our standpoint, when it comes to an individual with diabetes, we accept the fact that these folks are going to be on a statin, particularly if they're over the age of 40. So we try to adjust their anti-hyperglycemic regimen appropriately to account for any deterioration in glycemic control if they've been placed on certain statins.
So there was a question about mechanism of action of the medications.
Good question. Now let's start with the more popular GLP-1 agonists, right? You have trade names, Byetta, Bydureon, Trulicity, Ozempic, and Victoza. So basically, these are what we call GLP-1 analogs. So if you take an individual without diabetes, as soon as we eat a meal, there are certain cells in our body which release this hormone called GLP-1. And what it does is it tells your pancreas to produce what is called glucose-dependent insulin production, which helps to eliminate the glucose rise which happens after a meal. And it also tells your glucagon producing cells from the pancreas to decrease the production so that there is no post-meal surge of glucose. So that's what GLP-1 does. Now, when we do develop diabetes, this gets blunted. We make less and less of GLP-1. So what happens is we do not have that surge of insulin as soon as we eat a meal. And paradoxically, there's an increase in glucagon production, which causes a postprandial high from hepatic release of glucose. So it's kind of a double whammy. So that's where the GLP-1 agonists come in. They help to replace what our endogenous nature and endogenous GLP-1 would have done. So by doing this, it helps our pancreas produce some insulin, only glucose dependent. So if my blood sugar was already 70, it's not going to tell my pancreas to produce more insulin. So even if I was on insulin or if I was on a sulfonylurea and I was on this particular treatment as part of my regimen, if my glucose was 70 or 80, it's not going to tell my pancreas to produce more insulin. And interestingly, it has the added benefit of through some other mechanism telling my brain to eat less, my stomach feels full, and that helps with the weight loss. So clearly it's a huge advantage. And from our standpoint, the advent of GLP-1 agonists has enhanced and enabled individuals to adopt injectables much quicker. So there is no phobia. There used to be a lot of phobia when it came to needles. Thankfully, with more and more of these being used, and I'd like to applaud the efforts of our primary care physicians who have jumped on the bandwagon so earlier on, and they're using more and more of it. And this has enabled people who come to us where we can embark on multi-dose insulin regimen aggressively. Now, that is as far as GLP-1 agonists. Now, I'm sure what are the downsides? Nausea and vomiting are the commonest side effects, but people tolerate it as long as we remind them, give it some time. Let's go slow. Let's go on the lowest dose, wait for 4 weeks, see how we tolerate it. Then we'll go up to the next step. So we need to, because we need to win the war. I mean, because the longer they're going to stay on it, the better it is for them from a cardiovascular standpoint, renal standpoint, weight loss, etc. So I think it's a great option. Now, we don't want to use it if somebody has pancreatitis, because there are some concerns about pancreatitis with this class. And I'm sure they all come with a black box warning. I'm sure most of our patients freak out as soon as they get this printout from their pharmacist that this drug can kill and cause you cancer. Animal studies have shown there is an association with this class of agents and medullary thyroid cancer, which is the rare kind of thyroid cancer. I'm sure my colleague Satish would be here. He would say this is a very uncommon kind of thyroid cancer. The commonest kinds are papillary thyroid cancer. So if somebody has that, or if they have a strong family tree of multiple endocrine neoplasia, which includes medullary thyroid carcinoma, I would not use it in those individuals. Now, if you're going to look at the SGLT2 inhibitors, Invokana, Farxiga, Jardiance, Teglatro, these are the available agents. What do? Now, when if you take an individual without diabetes, there is what is called the renal threshold. There's a certain amount of glucose in your blood. After 180 milligrams, it's filtered. And then you have the tubules, SGLT2, which reabsorbs almost 80% of the glucose which was filtered, because glucose meets our energy needs. Now, on the other hand, if I develop diabetes tomorrow and my glucose levels are high and my kidneys are trying to filter the excess glucose which I don't need, I do not need my kidneys to reabsorb this glucose, but I have enough and more in my system already. So that's where these drugs come in. They are called the SGLT2 inhibitors. So what they do is they cause almost a 60% inhibition of these receptors. And by doing that, it eliminates glucose out of your system. So that's why you have glycosuria. So if you have one of your patients and you start this drug and they go for an insurance physical and they says you have too much glucose in your urine, they need to tell them, listen, that's what this drug is designed to do. I am going to see a lot of glucose in my urine because that's what it's designed to do. Now, one of the downsides of this drug is because it's causing too much glucose in the urine, there's a risk of urinary tract infection. There's going to be genital yeast infections. And of course, you're going to see commercials and attorneys about a rare condition called Fournier's gangrene, which is a serious, overwhelming sepsis of the perineal area. Thankfully, uncommon. But that is something which we have to discuss. Now, these drugs can also cause somebody to get dehydrated because they're going to go to the bathroom a lot more. There's going to be polyuria, there's going to be polydipsia, and there could be drops in blood pressure. So particularly in our elderly patients who are at a risk for dizziness, for falls, already on multiple lower agents, have vision problems, get up frequently at night to go to the bathroom, we've got to be very careful here because they could have drop in blood pressure when they stand up, they could fall. And so they're good drugs, all of them. I mean, plenty of benefits, but we have to be cautious. We have to make sure we choose our patients wisely. But more importantly, I think education is the key.
So the exciting thing is in 2021, we have so many different options for the management of diabetes that we really should not have a challenge in getting to our treatment goal. Would you agree, Prashant?
I agree, absolutely.
And
I'm sure, most of us who've been in practice here for several decades, we really had nothing. I mean, I remember we had metformin. If you failed metformin, I couldn't tolerate it. It was insulin. And I remember during our fellowship, if somebody would say, I do not want to take insulin, I'm not kidding. We had a glass box which showed an insulin syringe progressing to an IV catheter and a dialysis catheter, saying, okay, if you don't want to take insulin now, this is where we are heading for. I mean, it was a very rude way of encouraging somebody to go on insulin. But thank God, for all these devices, we are not here to postpone initiating insulin. Of course, we have to embark on insulin therapy earlier in some individuals. If somebody is catabolic, right? If somebody is symptomatic, they're waking with blood sugars in the 200s, 300s, they're losing weight, even though they have type 2 diabetes, or they've been started on steroids for whatever reason, they have to be on insulin temporarily. But again, thankfully, with all these agents, we can postpone insulin. And should it be? I think it's reasonable. And I think it can be used earlier when appropriate. But I think, like you said, we have so many options now which can make a huge difference.
And actually, with the GLP-1 RAs, if you're on a very low dose insulin for mealtime, we've actually been able to take you off insulin, or even the bolus insulin. So it really has helped to simplify the regimen and make more people get to their goal.
Yes, it's very rewarding.
Weight loss has helped tremendously as well.
You're absolutely right. It's very rewarding. I mean, people come to us, or we start them on insulin sometimes because they came in catabolic, and then they go back and see their family doctors, and they have embarked upon adding SGLT2 and GLP-1, and then they see that they're able to eliminate the mealtime insulin, and before long they've eliminated their slow-acting insulin. Boy, that's rewarding.
Yes. So there is another question that asks about resources in the community for healthy eating and living. And to that extent, the healthcare community has worked really hard. I don't know if Rupa is on. Rupa, do you want to talk about all the activities for the healthcare community and what they're doing for healthy living, especially?
Well, hi, Meenakshi.
Hi.
This is a surprise. I'm not expected to talk today, but yes, MVAPI has the advantage of having doctors who are enthusiastic, who are volunteers, and are committed to encouraging healthy living before people need medicines. Of course, if you need medicines, we're there. So as of now, monthly, we have 4 events. We have the once a month yoga, and we're trying to have the yoga match the topic of the month. So yoga for diabetes is this month's focus. We have the webinars once a month, and as today's, it was phenomenally useful. It was fun to listen to. It wasn't dry, it was interactive. And every month there will be a different topic. We also have the Bollywood workout, and that we've just started. It's going to be once a month. Maybe we can get it up to twice a month, but we're starting at once a month. And we're also having the heartfulness meditation every week. We have a flyer for this. We will share the flyers again in the MVAPI main group. They're also shared in the temple group. They're also shared in the Telugu group and the other community groups as well. And if anybody listening today has friends or personally are able to contribute to our society in any way to help improve health, we are happy to incorporate it into this MVAPI Living Better series. Does that sound good, Meenakshi?
Thank you.
Great.
And our yoga is next week. I will send the flyer again as usual. We're looking forward to a robust participation so we can keep this going year after year.
Awesome.
There was one more question about the benefits of supplements like bitter gourd and cinnamon.
Good question. The honest answer is we do not know. Experience is all anecdotal.
Right.
So when it is a position of not just me, it's a position of the American Diabetes Association. There is no compelling evidence as to its risks or its benefits. Now, if somebody wants to and like it, hey, I like bitter gourd, I'll take it. If somebody likes cinnamon, I'll say, don't buy a cinnamon tablet from Costco. Add a little bit of cinnamon to your coffee. So if anything, if you like it, I don't think it's going to cause you harm. But if it helps you, sure. But is there evidence that cinnamon, chromolinium pickle in it, and all these things make an impact? We have no compelling evidence so far.
There's one more comment about the increased risk of normoglycemic ketoacidosis from SGLT2 inhibitors and what you need to watch out for.
Basically, I think patient selection is important. Now, I'm sure many of you are in a dilemma at times to know or to come to the conclusion whether this individual has type 1 or type 2. So if I have somebody who is thin and looks and smells more like type 1 rather than type 2, I would not use SGLT2 inhibitors in these individuals because they are at a higher risk. Now, how is it easy for me to come to that conclusion? No. But at least if you say measure a glucose level along with a C-peptide, and if their C-peptides are somewhere above the middle, I would say, okay, they have some endogenous insulin producing capability. They probably can be considered for this. But if somebody's glucose levels are like 200 and their C-peptide levels are already very low, they are not making too much insulin. Now, these individuals who develop euglycemic ketoacidosis with SGLT2 inhibitors, one of the biggest reasons why is they lack insulin or they're insulin deficient. So that would help me make a decision as to whether I prescribe this particular agent or not. Now, on the other hand, if somebody doesn't fit that particular criteria, and I'll be comfortable prescribing this agent, but I will tell them these are things you need to watch out for. Drink plenty of fluids, keep yourself well hydrated, no ketogenic diet. And if you start feeling sick, you have nausea and vomiting, you head to the hospital and stop this medication. I would also encourage all our primary care physicians to stop using SGLT2 inhibitors at least 5 days prior to any elective surgery.
Lakshmi?
There's one more question.
Please.
Okay. What do you think of long-term effects as pertain to increase in hyperglycemia or diabetes with use of steroids with COVID treatment?
No, again, this is all of us are, I think, in a stage of infancy when it comes to COVID-19 and its disease state or its treatment. Long term, we have no idea. Now, we know that steroids are being used in a very short-term basis on a very select group of patients. So I do not know what the long-term effects are going to be. Now, having said that, we do know that individuals with diabetes when they are unfortunate enough to be infected by COVID-19, they do poorly. The outcomes in general are poor. And steroids in a hospitalized patient, I think, are the standard of care for COVID infections, as far as I know, because I have not taken care of these individuals. But I think that's part of the treatment regimen. Now, yes, in addition to the overwhelming stress of COVID infection and the release of stress hormones, including catecholamines, steroids, which lead to a significant degree of insulin resistance, their blood sugars can be high. And these individuals require fairly large doses of insulin. And of course, insulin is going to be the mainstay of treatment during the entire course of their hospitalization. With regard to the long term, we do not know, because these folks are treated with, as far as I know, dexamethasone for 10 days. I think that's my impression.
Yeah.
So I'm not sure about the long term effects of steroids in these individuals, because they are not going to be on it long term.
Right.
Now, on the topic of COVID, we also know that many folks with COVID-19 who never had diabetes were diagnosed with hyperglycemia. And we do not know whether it was COVID related or were these folks people with diabetes who remain undiagnosed. I think under those circumstances, an HbA1c would help at least give us some idea. So if somebody's hemoglobin A1c was 10 and they came in with COVID symptoms, you know, they've been hyperglycemic for several months. So these are some of the things I would add regarding COVID-19 and diabetes.
Right. So I think with the dexamethasone, not just with COVID, but with any condition where you give dexamethasone for a short period, like COPD exacerbation, that's one of the few times where sliding scale, so to speak,
Correct.
is a reasonable option. We try not to use sliding scale for the most part, but in certain circumstances, like short course of steroids, sliding scale is a good option just to control the high blood sugars related to the steroid use. But again, I agree with Prashant, there's really not long-term complications, it's just for a brief period.
To add to what Meenakshi just said, what we try to do is we tell our patients that anytime they are being placed on steroids, and there are so many conditions which they have to, we encourage them to let us know, because we like to train them insulin use. And typically this happens on weekends. So it's always a good idea to forewarn them to learn. I think it's good for anybody to learn insulin self-administration, because steroids are going to be used, whether it's arthritis, asthma, COPD exacerbations, and the ability to self-administer insulin and have a kind of a plan to deal with a steroid-induced hyperglycemia contingency, I think is the right thing to do.
So one of the questions was, when do you check insulin levels?
Honestly, when it comes to diabetes management, I do not measure insulin levels, but I would measure C-peptide in the appropriate individual, but I'm not sure whether they're type 1, type 2, what is their endogenous insulin producing capability. So to give an example, right, when you use GLP-1 agonists, the sooner you use them, the better, because they need to have, or somebody should have the ability to have endogenous insulin producing capability for them to work. Under those unique circumstances, maybe I get it. Otherwise, it's more often used to confirm an insulin resistant state, which you already know is there. Now, if you see somebody who's overweight, centripetal obesity, acanthosis nigricans, facial hirsutism, PCOS, we know their insulin levels are going to be high. So I don't think there's a really compelling need to measure it.
Okay.
Okay, I think that's it as far as questions go. Yeah. All right. Guess, thank you, Dr. Prashant Kumar and Dr. Meenakshi Patel. Yes, this was a very lively and very informative session. Yes, I hope all the participants have benefited from it. And thank you all for participating. Thank you, MVAPI, for making this possible and yeah, helping our community stay healthy. Thank you.
Thank you. Thank you for the opportunity. Thank you so much.
Thank you. I also want to thank Five Rivers for helping promote our programs. And again, just remind your friends and family, this is an event that occurs every month. So tune in and be healthy. Thank you.
Thank you. Have a great one. Thank you.